It's now my great pleasure to introduce to you Mr. Christopher Payten. Chris is an advanced speech pathologist in ENT at the Gold Coast University Hospital, Queensland, and a doctoral student at the University of Sydney. He has over 15 years of clinical experience in the UK and Australia as an SLP in the field of voice and head and neck oncology.
Thank you, Kate. It's a pleasure to be invited to come and speak in this forum. I feel a little bit indulgent that I'm just going to talk a bit about my research, but hopefully it provides some good insights into what we're doing to manage services during this time. So we know that voice disorders are common. It's reported that 1 in 13 adults across their adult lifetime may experience a voice problem, but actually as low as 10% may seek that medical help. So we know that people are persisting with problems, perhaps without seeking help or being able to get that access to help. A voice disorder impacts on physical, emotional, social, and employment well-being, with 1 in 3 people needing their voice for their work, teachers, lawyers, people working in call centers, taxi drivers, and they amount to a lot of sick days per year as well. And they're costly to the individual, to healthcare, and also society. So early intervention is very key to preventing decline and reducing healthcare costs. And that's a challenge for healthcare providers worldwide in any time, particularly at the moment. So the voice is a vital tool for communication of everyday spoken language. We all know that. Our voice is unique to us as individuals. It identifies us, and it can reflect a wealth of information about us, our gender, age, our education, social status, cultural origin, our emotional state, and our physical state as well. And the symptoms of a voice disorder can be far-reaching. A reliable voice can become disordered, we know, when a person's perceived quality, pitch, loudness, or vocal effort differ from others of a similar age or cultural group, or people who we work with or see socially every day. So why does a voice sound disordered? I'm going to talk a little bit about how the voice works and how we assess the voice so that we can understand how we can go around assessing this vital organ during this time. So we hear a voice is disordered or it's not the same, but how can we tell that it's different? What signs are there? A healthy functioning voice relies on a combination of things, physiological, biomechanical, and aerodynamic workings within the upper part of the body. It's powered from air in the lungs. The sound is sourced from the voice box, from the larynx, and it's filtered through the nose and the mouth, producing sound waves, which we refer to as acoustic signals. And that's perceived by the listener as the voice is produced. So it relies on optimal lung support. It relies on normal movement of our vocal cords or vocal folds, which are in the larynx. We need optimal closure of those vocal folds, optimal tensioning of the vocal folds, and the timing of vocal fold closure in relation to breathing out is really crucial as well. So it's very complex. So our assessment needs to be quite multidimensional to encapsulate all of those far-reaching effects of the voice disorder, from the physical changes to the psychosocial impact of it. So how do we assess the voice? We understand people's, or we try to understand people's symptoms through case history, detailed case history, through self-report questionnaires. And we want to know about the onset of the problem, how variable it is, any aggravating factors, and also those red flag symptoms that might mean that something more sinister is happening within the voice box, requiring more urgent assessment. We'll then interpret any signs from any clinical measures that we do. So Kate talked a little bit about some of those assessments that we do. We're very trained in listening and rating voices so that we can understand what's happening. We'll try and make judgments on the vocal quality, the pitch or the loudness of a voice so that we can understand which aspects of that mechanism are broken down or not working so well. And we'll also use objective assessments to quantify our interpretation and measure our outcomes. Usually, direct visualization of the voice box or laryngoscopy is done first. It's the first assessment that people will normally have, and I'm sure that people listening tonight with a voice disorder will have had the camera in the nose or the camera in the mouth to have a look at the voice box. And that's because it's most likely to pick up any structural or concerning pathological causes. But it's only a brief assessment of the voice box. We only get to look at that voice box during that moment period. And the other assessments that I've talked about are very important in putting together the picture of that voice difficulty. So typically, people with a voice symptoms, people with dysphonia, will be referred to ENT from their GP with a history of the symptoms that we talked about. And that initial assessment will usually include a case history and laryngoscopy or visualization of the voice box. And that's important so that we can identify any structural causes or any neurological causes with the voice. Then the ENT may refer to a speech and language pathologist, or we're called speech pathologists in the Australian healthcare. And speech pathologists will do continued assessment using the listening assessments, the perceptual assessments, the detailed case history, and any acoustic assessments as well. And we know that 40 to 60% of people who have a voice problem will generally not have any structural or neurological problems in the larynx. So those patients will generally be treated by a speech pathologist through voice therapy. So currently best practice is multidisciplinary assessment, including both ENT and speech pathology as a very minimum, so that we can make the best use of both levels of assessments. In specialist centres or in research centres, often combined multidisciplinary team voice assessment clinics exist to utilise the skills of both ENTs and speech pathologists. But in the public healthcare system in Australia, these multidisciplinary clinics are not readily available for every patient due to the availability of clinicians within those centres. And we see that patients will often wait longer than they need to for that ear, nose and throat assessment because the ENT clinics are very busy. And then this delays the access to speech and language, speech pathology services and voice therapy services. So the Speech and Language Pathology First Contact assessment is a model we've introduced where patients can be triaged much more quickly in that system. So the speech pathologist will see the patient first, conduct all of the recommended assessments, and then a medical review prior to any medical review to determine the true diagnosis or to determine the exact diagnosis, usually with laryngoscopy on top of all of the other assessments. In our model, the speech pathologist performs the laryngoscopy at the Gold Coast University Hospital and then presents this information to the ENT for interpretation. It's not a new pathway, but it's not a readily available pathway because research has not demonstrated how effective it is for those patients and for which patients. in the Gold Coast University Hospital, we've started to test this model and found that actually patients who see the speech pathologist in this speech and language pathology first contact clinic, on average, wait around 277 days less than if they would need to see the ENT. So we're seeing them much faster. We saw that 81% of those patients were able to go straight to voice therapy, straight to the speech and language pathologist. And only around 20% had to go back and see the ear, nose and throat doctors for continued intervention. Most of those people seeing the ENT doctors after that initial assessment still continued to benefit from speech pathology. However, a small percentage, 7% of those patients, actually needed to see the ENT much more urgently than originally thought when they were on the waiting list. So they were seen much quicker by both the speech pathologist and the ENT. And the benefit of that model is it's a one-stop assessment. It's a multi-dimensional assessment with the speech pathologist, with the ENT working in the background to assist with that diagnostic interpretation. But we need to understand how we can best triage the right patients for that first contact clinic, because it's not readily needed for every patient. Some patients do need to see ENT doctors much faster than they need to see speech pathologists. So my research is to investigate the speech pathology first contact assessment model, because we want to answer those questions. We want to know, is the pathway quicker for all patients? Whether they need to access ear, nose and throat doctors first or speech pathologists first. How does it compare to other models or the usual care pathway, which is obviously working well for many patients despite the delays in being seen? Can we use the model to triage people to better access ENT surgeons for those patients that need it? And who will best benefit for these models? Because it's not needed for every patient. We still need the multidisciplinary clinics where we can utilize ENTs and speech and language pathologists together. And we still need those ENT first contact clinics. Also, as part of my studies, I hope to engage with people who are affected by voice disorders and who have experienced that diagnostic process, so that I can inform the validity of my studies and make sure that we're measuring the right things. So I hope some people in the audience tonight may be interested, and we may be able to engage with you much more in future about that as my studies go on. But for now, we as healthcare professionals face quite a global challenge in the assessment and management of people with voice disorders, as Dan and Kate have both outlined. In our public hospitals in Queensland, the pandemic has resulted in quite a big change to how we deliver outpatient services, and it's changed how patients are able to access our services. In the first instance, clinicians were being pulled away from those outpatient services into much more critical clinical roles to manage any potential pandemic, as in other countries. Fortunately, we haven't seen that big onslaught on the public hospitals as yet. However, that has led to a reduction in face-to-face appointments, and particularly for our instrumental assessments, because we have to keep patient safety and staff safety first. Physical distancing is obviously an issue within our waiting rooms, and also access to personal protective equipment, as Dan and Kate have talked about. So certainly there's a reduction in the routine laryngoscopy or visualization of the larynx within our services that we rely on a lot for the diagnostic purposes for voice. And many of our services are actually converting to telehealth. Our entire hospital has been through a very big learning curve, down to the admin staff being able to teach patients how to access telehealth, to the clinical staff being able to adapt their assessment and their treatment protocols to help with patients over the telehealth as well. It's been a learning curve for all of us, but of course, sometimes opportunities come out of these crises. So for the interim period, we see the Speech-Language Pathology First Contact Clinic perhaps offers an alternative and immediate solution to help patients manage during this time. Otherwise, they would be waiting on ENT waiting time list to access their initial diagnostic laryngoscopy. And many of the clinical assessments that we do, such as the case history, the perceptual assessments, the patient-reported outcomes that Dan and Kate have both talked about. We can listen to the voice, we can record the voice for acoustic analysis, and that can happen over telehealth with a little bit of perseverance and some good equipment. Laryngoscopy is not available via telehealth, but it's still essential to complete that diagnostic process. So we can perform a lot of measures before we get to laryngoscopy, which is in a sense the same thing as the face-to-face speech pathology first contact assessment does. So the application of a telehealth model as a speech pathology first contact perhaps is a way of providing that multidimensional assessment. It can be used to assist with triaging patients for urgency of when they need that laryngoscopy, referral to other services. And we can also provide some voice care advice and some treatments while patients are waiting for that diagnostic laryngoscopy within that telehealth model. So faster access for patients, hopefully, and some advice and treatment along the way as well. So we're rapidly learning to be creative with the way we deliver care, with the technology we had or technology that we didn't even know we had. And we're starting to offer support and treatment to our clients through our video conferencing models. And that's it's great to see that rolling out through public hospitals as well as in the private sectors and the private clinics as well. Some of the barriers within the public hospitals with delivering the telehealth services is around access to equipment, but also ensuring that the right governance and the right systems and processes are in place to protect people from things like cybersecurity and all of those issues that perhaps are risky with the public health system, with the statewide public health systems. We're constantly working to make our service more flexible because the client's needs are very important to us. That's why we do our jobs. And hopefully we're enabling people to still access those highly specialist services from remote or rural locations, but also for those patients who are unable to access hospitals. And our research is focused on improving equal access to highly specialist services. And that's very important to me personally, but also within the team where I'm conducting my research, the Dr. Liang Voice Program. So despite those challenges that are standing in our way, we are making some great gains. So that's it from me. Short but sweet, but I hope to address any questions further on in the evening.